Han, gising na. Kain na tayo ng breakfast. Magsisimula na yung Olympics.
Okay.
Han, nainom mo na ba yung gamot?
Wait lang. Maganda kasi yung laban ng Brazil eh. Ito na oh. Uy! Yes! Goal! Woo! Han! Parang set ng ano ko ah.
Ha? Ano nangyari sa'yo?
Hirapan na huminga eh.
Dito ka muna. Dito ka muna. Okay, sige, let's go! Where are you going? Check for the pulse. Tachycardia. Okay, team, let's transport the patient to the ambulance.
Oh, kamusta yung cancer patient mo? Patay na ba?
Grabe naman.
Hindi pa ba? Ano yan, doktora?
Schedule pa, no?
Death schedule ba tawag dyan?
Hindi naman daw.
Ikaw naman, doktora, ano yan? Review ka dyan.
"53-year-old male, substernal pain, Makindi, confused sweating."
Huwag sa akin. Ang tawag dito.
Ano na po ba nangyari, sir?
Bigla na lang po sumakit yung dibdib niya.
Kailan po ito nangyari?
Kanina po umaga.
Ano pong ginagawa ni sir?
Nanadala po na rin yung Olympics.
Meron po ba siyang ginagawa bago yun? Galing po ba siya sa labas o ibang gawain?
Kumakain lang po siya ng agahan eh, habang po nangyari po yun.
Okay guys, we have a 53-year-old male patient, severe substernal pain. Differential symptom.
Patient is a 53-year-old male, a diplomat to Brazil. He is a known hypertensive for 15 years. He is supposedly maintained on metoprolol 50 milligrams once daily, but is reported to be poorly compliant. He also has a 25-year history of smoking. He was found to be sweating profusely and is tachycardic. We gave him nitroglycerine, but there is no relief.
We performed ancillary tests such as ECG, which showed ST elevation. We also performed radiograph, complete blood count, and lipid count.
Different lab tests were performed such as lactate dehydrogenase to detect the level of LD1 and LD2, creatine kinase, specifically CKMB, to detect damage in the heart if there is event of myocardial infarction, cardiac troponin I and cardiac troponin T to test the degree of myocardial damage. This is the most sensitive and specific biomarker for myocardial damage.
Based on the symptoms presented by the patient, substernal pain, profuse sweating, tachypnea, no relief with administration of nitroglycerine, and based on the cardiac marker test performed, there is a
possibility that he has myocardial infarction. MI is heralded by severe, crushing substernal chest pain or pressure that can radiate to the neck, jaw, epigastrium, or left arm. ECG and MI shows abnormalities in ST segment and T-wave inversions. Risk factors include age, gender, hypertension, smoking that damage the interior walls of arteries, including arteries of the heart, allowing deposits of cholesterol and other substances to collect and slow blood flow. Smoking also increases the risk of deadly blood clots forming and causing a heart attack. Microscopic morphologic changes in the heart. From normal cardiac muscles, these cells show coagulation necrosis with loss of nuclei and striations, brisk interstitial infiltrate of neutrophils on the first 3 days. 7 days after the attack, there is a beginning of disintegration of dead myofibers with dying neutrophils and early phagocytosis of dead cells by macrophages at infarct border.
Well, since the patient manifested those symptoms and he's from Brazil and has a frequent history of travels,
I suggest of Chagas disease. It is caused by a protozoan parasite called Trypanosoma cruzi, which is common in South America, particularly in Brazil. This matches with the patient's current residence in Brazil. This can be acquired through oral ingestion of a contaminated food product. This again tallies with the patient's complaint of severe substernal pain while having his breakfast. Clinical manifestations that support this diagnosis are body pains, hemoptysis, dyspnea, and tachypnea. According to some journals, this also causes severe pathologic changes in the alveolar walls that include alveolar wall thickening and inflammatory infiltration. This coincides with the chest X-ray obtained from the patient that revealed multiple confluent alveolar opacities with air bronchograms in both lungs.
in addition to this chest pain and elevated ST segment, I
Also suggest infective endocarditis due to chest pain and ST elevation.
Okay guys, based on our test and results conducted, we can roll this all out. Okay, do we all agree that our final diagnosis is myocardial infarction?
Coronary angiography was performed. Shows thrombosis in the right coronary artery.
Dok, kumusta po yung asawa ko?
Buti na lang misis, nadala nyo agad si sir dito sa ospital. Kasi kung hindi, ito yung mga complications na pwede niyang makuha.
Heart attack or stroke due to hardening and thickening of the arteries. Aneurysm, when increased blood pressure makes blood vessels weak and bulge. Heart failure, where the high pressure strains the heart and can cause the heart muscle to weaken and work less efficiently. Coronary artery disease. Arteries narrowed by coronary artery disease don't allow blood to flow freely through your arteries. This causes chest pain, a heart attack, or irregular heart rhythms.
Buti na lang po talaga. Dok, ano po yung nitrogelatin po? Yung po, ano po yun?
Nitroglycerin po. Bale, ang nitroglycerin po kasi
Nitroglycerin used to prevent chest pain or angina. Angina occurs when the heart muscle is not getting enough blood. This drug works by relaxing and widening blood vessels so blood can flow more easily to the heart. This reduces the heart's workload and the amount of oxygen needed by the heart, thus preventing chest pain. Treating high blood pressure during surgery, controlling congestive heart failure associated with heart attack, treating chest pain in certain patients, and lowering blood pressure during surgery. The major acute toxicities of organic nitrates are direct extension of therapeutic vasodilation, orthostatic hypertension, tachycardia, and throbbing headache.
Han, pwede na pala tayo lumipit ng room mamaya. Alis lang ako sandali lang.
Tan, parang sakit ng katawan ko.
Ano nangyari sa'yo? Ba't parang init mo? Nurse! Nurse! Okay ka lang ba? Ano nangyari sa'yo? Doc! Doc! Ano po nangyari sa kanya? Wala pa tulong.
So guys, why am I here?
We've called to give you updates on the patient.
So, what happened?
On the patient's fourth hospital day, his chest pain was already controlled. He was scheduled to transfer to a regular room when he complained of body pains, productive cough, and high-grade fever.
2 days after that, the patient's cough persisted, accompanied by hemoptysis, dyspnea, and tachypnea. CBC showed leukopenia, and chest X-ray revealed multiple confluent alveolar capacities with air bronchograms in both lungs. We gave the patient Cefixime 200 milligrams twice a day, but there were no improvements. Sputum culture revealed gram-positive cocci in clusters, coagulase negative.
What do you think happened?
We originally considered worsening of his bronchitis, but we decided that hospital-acquired pneumonia is more likely.
So, why did you consider these differentials?
Well, along with the symptoms that the patient presented with, he also has a history of 20 back years of smoking, and he has impaired immunity, and due to his COPD, he has chronic use of inhaled corticosteroids, which increases his susceptibility to infection.
The expression of gene ICA ADBC results in the production of several polysaccharides responsible for the formation of a hydrophobic film. Staphylococcus epidermidis entry to the body is facilitated by the adhesion of its biofilm to a medical device used in invasive procedures. The bacteria invades and proliferates in the tissue and reaches the pulmonary circulation, causing hospital-acquired pneumonia.
Cefixime, which is characterized as a broad-spectrum antibiotic, produces the antibacterial activity by inhibiting peptidoglycan synthesis in the bacterial cell wall. Cefixime is a beta-lactamase-stable third-generation cephalosporin, is an effective antibiotic with the longest half-life. Third-generation cephalosporins like Cefixime are notorious for inducing resistance among gram-negative bacilli. Drug resistance to Cefixime is due to the alteration of resistance mechanisms, acquisition of resistance genetic element from other bacteria, and genetic changes in bacteria. The continuous use and often abuse of the drug have led to an increased resistance to Cefixime.
So, what now?
The patient is now hooked on a ventilator and his health has deteriorated.
So again, why am I here?